after showing my disclosures. I will start saying that the coexistence of atrial fibrillation and non-ST elevation acute coronary syndrome, which is generally treated by PCI, is a epidemiologically relevant issue, since it is estimated that about 5 to 10% of patients with atrial fibrillation then develop non-ST elevation ACS and undergo PCI, and at the same time 7 to 10% of patients with non-ST elevation ACS then may develop atrial fibrillation. And the problem stems from the fact that in these patients we need to prevent, on one side, the stroke risk associated with atrial fibrillation and the risk of recurrent ischemic events and stent thrombosis associated with the acute coronary syndrome and stent implantation, while at the same time trying to limit the inherent increased risk of bleeding. And the problem is that the two gold standard treatments for the two different situations are suboptimal for the other situation, in that dual antiplatelet therapy, which is the standard for non-ST elevation acute coronary syndrome, and stent, is stronger in the preventing recurrent ischemic events and stent thrombosis, while being weaker in preventing stroke. Whereas oral anticoagulation, which is the standard for stroke prevention, is obviously stronger to prevent stroke, but weaker to prevent recurrent ischemic events and stent thrombosis. This is the main reason why the current recommendations tell us that in patients who have at the same time an indication for oral anticoagulation, namely atrial fibrillation, and suffer from an acute coronary syndrome and or undergo stent implantation, then they need to be treated with the so-called triple therapy, including oral anticoagulation, aspirin, and clopidogrel. As we can see, the recommendation is a class 2A, which means it should be given, this treatment, with a level of evidence C, meaning that it comes from non-randomized trials, observational studies, and consensus of experts. Actually, these recommendations C is based on some data. We have data which, as I said, don't generally come from randomized clinical trials, but this is a meta-analysis including 6 studies for a total of 1,500 patients, showing that indeed a triple therapy compared to dual antiplatelet therapy significantly decreases the incidence of major adverse cardiovascular events, cardiac and stroke, while, however, paying a price in terms of bleeding, which we see is increased more than twofold. So the risk of major bleeding with triple therapy compared to dual antiplatelet therapy is 2.5-fold higher. This is why the same recommendations I mentioned before also give us some advice on how to carry out this triple therapy, just implementing carefully some bleeding avoiding strategies. The first one is to try to limit the peri-procedural bleeding by using the radial approach, by trying to perform the procedure without interrupting oral anticoagulation with warfarin, and not using GP2B3A inhibitors. Also, we should try to reduce the intensity of oral anticoagulation, in this case with warfarin, targeting an INR between 2 and 2.5. Also, we have heard that before, we should try to avoid in triple combination the newer P2Y12 inhibitors like prasugrel and ticagrelor, because they have shown to be associated to an increased risk of bleeding compared to ticagrelor. Also, we should try to limit as much as possible the duration of triple therapy, and possibly, and I put a question mark because to me this recommendation is not conclusive, we should try to reduce the intensity of the overall antithrombotic therapy, namely by withholding aspirin and giving just a P2Y12 inhibitor. I put the question mark because this recommendation is based essentially on this study, which is the VOOST trial, which indeed showed that patients who were randomized to dual therapy, vitamin K antagonist and clopidogrel, compared to those who were randomized to triple therapy, vitamin K antagonist, aspirin, and clopidogrel, actually had a dramatically decreased incidence at 1 year follow-up of total bleeding, which we can see was decreased by more than 60%, without paying any price in terms of efficacy. Actually, the overall incidence of stroke, death, MI, revascularization, and stent thrombosis was again significantly reduced by 40% compared to triple therapy in the dual therapy group. We need to consider, by the way, that in this study, the population who suffered from an acute coronary syndrome was only less than 1/3. So as we know that these patients have an increased risk of recurrent events, we cannot be confident that this superiority in terms of efficacy shown by dual therapy is actually applicable also to these patients at increased risks, like those with ACS are. This is one of the limitations of the study. Another limitation is that it was too underpowered to be sure that the efficacy results are reliable. And also we all know that clopidogrel has, at least pharmacologically, a large proportion of non-responsiveness, so it makes not completely sense that a patient getting just one oral anticoagulant and clopidogrel can be properly protected against stent thrombosis. So we need more data. It could be, by the way, that a dual combination where the P2Y12 inhibitor is not clopidogrel, but is one of the two newer ones like prasugrel or ticagrelor, which, as we have said, are more potent, can be an option. And indeed, this is an observational experience, as we can see, of very limited size, carried out retrospectively in Sweden. But in any case, it suggests that a dual combination where the P2Y12 inhibitor is ticagrelor may be at least as effective and safe as the conventional triple combination. But at the present time, we don't have recommendation regarding the use of dual therapy in this population, except for the cases at very high bleeding risk and associated low risk of recurrent events. Current guidelines, and these are the most recent ones which have been released at the latest European Society of Cardiology Congress last August, clearly recommend us to generally use triple therapy, starting from a stratification of the bleeding risk, not to decide the type of antithrombotic therapy, but to decide the duration of the different strategies we need to use. So in a patient with low bleeding risk, we should start with a course of triple therapy which may and should be carried out for 6 months, after which we should drop one of the two antiplatelet agents, either aspirin or clopidogrel, continue up to 1 month with this dual strategy, and then after 1 year has passed from the index event, just keep on with the oral anticoagulation alone. The same strategies are suggested for patients at increased bleeding risk, with the only difference that, and we have just heard that we can do that, with the only difference that the triple therapy can be prolonged only for 1 month. But most of the recommendation we have and most of the evidence on which these recommendations have built on are based on patients in whom oral anticoagulation was carried out with vitamin K antagonists. But what about NOACs? We know that all NOACs overall have a safety and efficacy profile at least comparable to that of vitamin K antagonists, and in some cases they are also superior. And also they are more convenient to manage. So it could be appealing to switch to these new agents. Actually, we don't have very many data regarding triple therapy or combination therapies in patients with AF and PCI with these drugs. We have actually these sub-analysis of the RELY trial where a very small proportion of patients, it was only 4.5%, received two antiplatelet agents throughout the study, whereas about 40% received at least one antiplatelet agent throughout the study. Well, from this sub-analysis, we can see that regarding major bleed, the major bleed incidence, of course, the absolute number of events increases as much as we add antiplatelet agents, but the relative risk of major bleed compared to oral anticoagulation alone, while, as I was saying, is increasing as much as we add antiplatelet agents, appears to be irrespective of the anticoagulant we use. This means that regardless of the fact that the anticoagulant is warfarin, the bigger than 110 or the bigger than 150, the relative risk of bleed is the same, suggesting therefore that NOACs can be an option. And indeed, in these recent guidelines regarding myocardial vascularization, it is stated that in patients with ACS and atrial fibrillation, we should use triple therapy comprising clopidogrel and aspirin and some kind of oral anticoagulation, either new or old. Things may change, but at this time we can see these recommendations. We have also seen before that, as I was saying earlier, we should try to limit the duration of triple therapy and then switch to a dual therapy and then switch again to NOAC monotherapy when we use a new oral anticoagulant, with the possibility to adapt these time frames depending on the weight of the individual risk factors for bleeding or for atherothrombotic events. So even if the standard recommended duration of triple therapy is 6 months, we could reduce to 3 or 1 if there are some factors which move our pendulum throughout an increase towards an increased risk of bleedings, or on the other hand, have it during longer if we believe that the risk of atherothrombotic events is higher. I was saying before that possibly we will have some adaptation in this recommendation considering this just released studies, the Pioneer AF PCI trial. It has been published last Monday night, and it is of interest because it is the first one of large size where patients were randomized to 3 different options. The group 3 was the standard triple therapy option with VKA. Group 1 was a VUST-like strategy, rivaroxaban, but reduced dose and just one antiplatelet agent, whereas the group 2 was a ATLAS-ACS-like strategy where the dose of oral anticoagulant used in triple combination was the very low one used in the ATLAS-ACS trial. Well, we can see that the safety of the 2 reduced intensity strategies was significantly higher than the conventional triple therapy. At the price, apparently, again, there are very many limitations in this study, but apparently with no increased risk of adverse events. There is one last question, in my view, to be addressed. This is a proposal we have developed together with Professor Huber, Ageval, and Lipp, which is relative to another scenario which is commonly not included in guidelines and not really discussed. That is the atrial fibrillation which develops early after an ACS and stenting. In this case, we need to choose between several options of oral anticoagulation. While in a patient coming on an oral anticoagulant, either a warfarin or a NOAC, we could and may leave the patient on that agent. But if a patient is not anticoagulated yet, then we need to make a choice. And of course, this is debatable, we have discussed about it, but we believe that in general, the first option should likely be a non-vitamin K oral anticoagulant, according to these suggestions. To conclude, I think that in patients with non-ST elevation ACS who are generally treated with PCI and atrial fibrillation, an initial course of triple therapy, oral anticoagulation, aspirin, and clopidogrel is generally recommended. Bleeding avoiding strategies should be carefully implemented throughout triple therapy. ongoing oral anticoagulation should be generally confirmed, but NOACs may be preferred for new onset atrial fibrillation. Thank you for your attention.